This talk also talks about what we look for when we're going for contracts, for contracted providers. And the one thing that I've seen, and I wonder if you've seen this too as a trend recently, is that I'm seeing more switching and more competition out there, in the sense that we used to go and you'd see these ED groups, often they were very local ED groups, had been there in the hospital for 15, 20 years. But now I'm seeing a lot of switching and changing. So we realize from our perspective, it's getting more competitive. And from your perspective, I know you're facing that too, right? Because as an administrator, there's that implicit threat now. Again, I go back to this is a business that we're running now. Everything is a lot tighter. There's that implicit threat that I know you've been in this hospital for 20 years. I know we love you guys and it's great, but you know what? We need some performance here and we have options now. So we realize that's out there. And as I said before, we don't really like to employ physicians and we're looking at contracting. So I always like to go back to history, because why do we even have contracted groups now? So this is a hospital that I worked at in Westminster, Maryland, Carroll Hospital, Carroll County Hospital. Here's a picture of it in 1960 when it opened. When it opened in 1960, the emergency room, if you had an emergency, quote unquote, you would walk up to the door here in the hospital and they had a bell. You would ring the bell, and they had a house physician who would answer the bell, and that's how you got treated, okay? And in 50 years, it's amazing to me. So now, you know, we're about 25 miles from Baltimore, and so now we have a very sophisticated, complex ED and a close relationship with shock trauma at University of Maryland, and we can get somebody in shock trauma in about 5 or 10 minutes. So that's why we're doing this now, because it's changed. So when we look at the services that have been outsourced over the last few years, I find this very interesting. It starts in 2006, 2008, 2012. So if you look at 2006, most of the outsourcing that we did really weren't physician services. Okay, we have, you know, imaging on there, lab, you could say pathology, but it was more, you know, outsourced specialty services. Again, we had more of that medical staff model, right? We had plenty of physicians. 2008, look, here's ED, hospitalists, whatever that is. I don't think we really knew what that was at that time, you know, and anesthesia. And 2012, look at this, anesthesia, ED, imaging, hospitalist. So you can see that there's a trend towards outsourcing these very complex systems that are physician-based in the hospital. Why do we do that? The number one reason we do that is that this whole thing has become very, very complex, and we need the expertise. A lot of times, you know, the local groups, you know, could not necessarily provide that level of expertise that we needed. So you could see moving up, it wasn't necessarily cost service, cost savings, or revenue. It was more having that expertise. So that's what we're looking for. We're looking for the expertise, and whether that can be done at the local level or through employment, that's what we need to assess. Okay, why do we like ED contracts? Why do we like contracting out the ED instead of employing physicians? Well, we like it because companies can provide some depth and some bench strength. So if we need to switch out physicians, it's there. And it can happen relatively quick because they do have that bench strength. That we don't have to deal with a lot of the administrative stuff like the malpractice fees, hiring, firing, supervising, training, and administering the physicians. Hopefully, the cost is lower through a couple of reasons. One is through standardization and economies of scale, and of course the other one is the concept being that the larger groups can get better rates, and therefore the subsidies would be less. Up-to-date medical knowledge and delivery, and actually giving ourselves some political cover with the community docs in the sense that when you bring in an expert, when you bring in a national firm, it has that sort of, you know, that brand image that they really can bring to the community. Why do we not like ED contracts? Okay, so these are the reasons that we wouldn't do it, And this is sort of the checklist as you're looking at contracting with hospitals. How do you address some of these things? I talked about the conflicting incentives before. We want to make sure that all the payer contracts and payer conflicts, that those don't really exist. Service breadth. I worked at a hospital recently where we sort of had a challenge. We wanted to do pediatrics, but we didn't have a lot of pediatrics, but we wanted to provide that service. So it was your standard chicken and egg type of thing, because the outsource, this was one of the national firms that we worked with, they didn't really want to commit that resource to have a pediatrician, a pediatric emergency physician in there, because we didn't have that volume. So that was sort of a conflict sometimes, is that from the perspective of the large groups, does it fit their business model to provide that resource? Just sort of parenthetically, we actually worked through this by doing a deal with the Children's Hospital of Philadelphia, and they were able to take care of that, so that actually worked. Problem docs, if they deal with the problem physicians, it's great. If they don't deal with the problem physicians, it's a problem for us. Turnover, sometimes you have a lot quicker turnover, that you don't have the people stay in place and that sort of steadiness over time. Loss of control over what's going on actually within the group and how it's managed. There may be some challenges with sort of a non-local flavor, especially in some of the more rural and suburban communities, where there's cultural issues or cultural fit issues. Cost, if the cost is too high, and IT interface, if that gets to be a problem. Okay, so I'm going to go through each of the different types of groups and what the pros and the cons are for each of them. Okay. So advantages of the mega groups, the big guys, the national firms. So this is something you need to understand about hospital administration. Hospital administrators are very, very risk averse. They want to do the safest thing. It was funny, when I was doing hospital consulting, when you'd come up with an idea, the first thing the hospital administrator would say is, show me 10 other places where this has happened. Can you imagine if Apple ran that way, right? Show me 10 other companies that created an iPhone before they had an iPhone. So they're very risk averse. The easiest, safest thing for an administrator to do, whether it's a large consulting project, so a lot of times you see these big consulting firms in and they spend huge dollars with these consulting firms, or whether it's a contracted service, is to say, these are the nationally recognized national experts. Okay, so these are the leading, cutting edge, innovative services. And so that's the easiest thing to say, I'm going to put one of these up there just to say that I'm giving you the absolute best, for no other reason than that. Okay? The other thing that's nice now about the mega groups is, as we see more and more consolidation, the ability to cover a wider geography. So for example, this hospital company I'm working with now, we actually contract with several different groups, but we may enter into a single contract so that they can cover a wider geography across multiple states. Economies of scale, as I said before, may reduce the subsidies, so that's good. A national pool of physicians, very effective billing and revenue cycle, so they know how to do this. They know how to get the dollars in the door, and that's not a big problem. Stability and financial viability, and finally, bringing the best practices, the innovative best practices to bear. Advantages of regional groups, and I sort of define a regional group as not within a very specific geography, but more of maybe like a statewide or multi-state geography. The nice thing about these groups, and I worked with these a few times too, is that there is scale, some scale there to provide and augment immediate manpower needs, especially if you're in the same, for example, state. So if you have somebody living within, a 30 to 50 mile radius. They're committed and they know the local geography, they know the different relationships between the hospitals. They know the state of the art in the area, they can bring local medical practitioners. They have leverage with payers. Remember, payers are still very state specific. You can do national contracts with payers, but in most cases, it's very state specific. So they can get leverage within a state, within a Blue Cross or an Aetna, to get very good payer rates and stability and financial viability. Okay, so a local independent group. This is the advantages of local independent groups, is this loyalty. You know, I talked about this thing about where we've had groups in here for 15 or 20 years. You develop that loyalty. You develop that working relationship. And for some of these hospitals, that really means a lot. This personal feel, this interpersonal relationship with the different practitioners, is that the ownership is actually local, and there's a vested interest in the local community. Especially with the not-for-profit hospitals, this is a big deal that the people are invested deeply into the community. Is that there's that collegiality with local colleagues over time. That people like the local area, they live here, they've established their homes, they raise their families here. You're not necessarily going to have a problem with a physician coming in from some other geography who may or may not fit with your local geography. They maintain their independence. So as we were saying earlier, they still have the incentive to be very, very productive. And you get longer tenured staff in general, not quite as itinerant. So here are the advantages of the employed physician groups. Okay, this is hospital employed groups. You still have that loyalty and that interpersonal relationship because these are people who are going to be here over a long period of time. You now have control over the leadership. Remember, I told you the leadership and who they appoint as a leader is absolutely critical, and personnel decision making. So you have a direct relationship in terms of making those hiring and firing decisions. There's that consistency of mission between the hospital and the physicians. We're on the same team. There's no divided loyalty. We're all together in this. There's no loyalty to the contracted group. We are the actual employer. And we can manage and set the compensation a lot easier and much more flexible than a contract with a contracted group. We can directly go in, and when we want to make compensation changes to incentivize different types of behaviors, we can actually do that. More advantages is that if it is a large health system with multiple hospitals, we may have the scale to sort of create, our larger employed groups. So, for example, Intermountain, for example, I believe you're employed, right, with the several different hospitals in the system.
Actually, the ER group is not, but we may soon be.
Okay.
They've carved out one by one. They're beginning to employ, like they have a huge practice that is multi-specialty, and I think that's what's happening around the country. These small MSOs are starting, and you get these big, huge groups.
Right.
And you fight to stay independent, don't you?
Okay. It's tough when you have an employed physician and you're in an employment relationship. It gets really hard for us to move them out. From our perspective, from admin, it's easier to call our partners at Team Health and say, look, this guy's just not working out. You got to move him out, get somebody else in here. Much more difficult when you're in an employment situation and you're the one who actually has the contract with the physician. Very, very difficult to do. I mentioned before, doctors are not the greatest employees, but that's changing, I think, as the generations are changing, as we're moving forward. And the advantage, again, as I said, is that you can actually put incentives into the contract to make it consistent with what we're trying to do. So just a couple comments on challenges for the future. Again, this idea of the incentives, building in the incentives, whether it's in the contract or it's in the employment compensation agreement, so that those incentives are driving what we need to accomplish in population health. Utilization management, quality, patient satisfaction. More objective relationships with local community physicians, collaboration, and appropriate ED utilization. This whole thing of managing the changing face of ED that we've been talking about the last 2 days, how are we going to manage the shift in utilization and shift to other venues, and then how are we going to work together? And this is something to really think about, especially for you that are starting to contract with hospitals. What's the value proposition that you're bringing to me under these risk-based and population health models? How can you actually get out in front and be the leader saying, look, we have a better model for helping you manage utilization across the entire spectrum, across the continuum? That's what we're going to be looking for in the future moving forward.